Hello, and welcome to the spring edition of Sepsis Chatter. Today, we will review the upcoming changes related to the SEP1 Severe Sepsis and Septic Shock Management Bundle, beginning with July 1st, 2024 discharges. We will also discuss 3 challenging case scenarios that required QualityNet question and answer submissions. The information related to the data element updates is based on the Specifications Manual for Hospital Inpatient Quality Measures, version 5.16, for discharges July 1st through December 31st, 2024. Also, portions of this presentation are based upon the current version of the Specifications Manual and QualityNet question and answer responses. As a general abstraction reminder, always refer to the version of the Specifications Manual that corresponds with the discharge dates being reviewed. Let's review the goals for today. At the conclusion of this presentation, the attendee will be able to apply new abstraction knowledge to determine which new general data elements are required and which are optional, obtain a working understanding of the gender identity, sex assigned at birth, and sexual orientation data elements. Also, apply the challenging abstraction examples to similar scenarios. The only changes for discharges beginning with July 1st are related to the general data elements. So let's review what general data elements are. Data elements that are collected by hospitals for each patient record. Data elements required for each episode of care record submitted. Data elements used to identify the hospital on each patient record required for each patient level record submitted. And lastly, patient demographic data required for each episode of care record submitted and used for risk adjustment analysis where applicable. Today, we will focus on the patient demographic data that includes sex assigned at birth, gender identity, and sexual orientation, since these are evolving and do warrant further discussion. Before we get into specific definitions, let's take a look at which general data elements are required versus optional. Some examples of required general data elements are admission date, birth date, discharge date, ethnicity, diagnosis codes, procedure codes, and sex has always been required as a general data element. However, for July 1st discharges, it's been redefined to include sex assigned at birth. Some examples of optional general data elements are gender identity, national provider identifier, and sexual orientation. We will focus on the 2 optional data elements, gender identity and sexual orientation, for the purposes of this presentation. Of note, it will be up to your individual facilities as to whether this information will be included in your abstractions beginning July 1st, 2024. The new data element, sex assigned at birth, is the only required data element of the 3 that we will be discussing today. So the definition for this is the patient's biological sex assigned at birth. The suggested data collection question is, what was the patient's reported sex assigned at birth? The allowable values are female, male, intersex, none of the above, other or unable to be determined, or preferred not to answer. I'd say when answering this data element, think biology. That's the best advice I can give you. The allowable values for female, male, and preferred not to answer are self-explanatory. However, how do we answer intersex and none of the above, other, or unable to determine? Allowable value 3 is intersex. People who are intersex have reproductive or sexual anatomy that doesn't fit into an exclusively male or female sex classification. Intersexuality may affect a person's genitals, chromosomes, hormones, reproductive system, or gonads. Approximately 2% of the world population have intersex traits. Sometimes it's discovered during fertility treatment or as a result of imaging. Sometimes these intersex traits may not be evident until the puberty or adulthood. It just depends. So also for allowable value 4, none of the above, other or unable to be determined. This is not the same as a patient who refuses to answer. Some of the information may be that they don't describe themselves as female, male, intersex, or describes themselves in other terms, or if the medical record does not include information about the patient's biological sex assigned at birth, you would select value 4. Consider the sex to be unable to be determined and select value 4 if there is contradictory information or if the sex assigned at birth is not documented or not available. The data element gender identity is the first optional data element that we're going to discuss. The definition is a multi-tiered question asking patients to describe their gender identity. The suggested data collection question is, which term best describes the patient's gender identity? The allowable values are as follows: man, woman, non-binary, transgender, none of the above or unable to be determined, and prefer not to answer. In this case, you could select all that apply. It's not necessarily a one answer question. According to the notes for abstraction, it's acceptable to select up to 6 values. If values 5 and or 6 is selected, it is acceptable to also select values 1, 2, 3, and or 4. If the patient does not describe themselves as non-binary, transgender, and or describes themselves in other terms, you would select 5. Keep in mind that value 5 is not the same as prefer not to answer. So consider the gender identity to be unable to be determined and select value 5 if the sexual orientation is not documented or not available. The inclusion guidelines for this data element clarify who would be included in the following values: 3, non-binary, 4, transgender, 5, none of the above or unable to be determined. The following is included: trans man or transgender man, female to male, FTM, trans woman or transgender woman, male to female, or MTF, genderqueer, gender fluid, gender variant, and lastly, questioning or unsure of their gender identity. The last optional data element to discuss is sexual orientation. The definition is a multi-part question which describes the patient's sexual orientation, including identity, which is a person's core internal sense of their sexuality; attraction, which is a multidimensional concept that includes the genders to which a person is attracted and the strength of this attraction, including whether a person feels attraction at all; and behavior. Behavior is a multidimensional concept that includes the genders of the sexual partners, specific sexual activities, and the frequency of these activities. A person's sexual orientation does not always align with the behavior or attraction. An example would be a bisexual woman who is happily married to a man, but is also attracted to women. She possesses the attraction to women, however, she does not act upon this attraction, which would be the behavior. The behavior is that she's married to a man, she's happily married to a man, however, she is still attracted to women. The suggested data collection question is, which term best represents how the patient thinks of themselves? The allowable values are gay, lesbian, straight, which is not gay or lesbian, bisexual, none of the above or unable to be determined, and prefers not to answer. Allowable values 1 through 4 and 6 are self-explanatory. However, we need to break down allowable 5 a little bit further. The inclusion guidelines for abstraction. Value 5 includes, but is not limited to, the following: queer, polysexual, omnisexual, sapiosexual, or pansexual, asexual, two-spirit, has not figured out or is in the process of figuring out their sexuality, mostly straight but sometimes attracted to people of their own sex, does not think of themselves as having a sexuality, does not use labels to identify themselves, or does not know the answer. Again, number 5 is not the same as a person who's refusing to answer the question. So that concludes the Specifications Manual updates for discharges beginning July 1st, 2024. Next up, we have abstraction challenges and resolution that are related to provider addendums, lesser volume of crystalloid fluid documentation, and crystalloid fluids running prior to and following an order for 30 cc's per kilogram. I'd like to review some background related to provider documentation before we get into discussing an addendum. So this information was added to the Introduction to the Data Dictionary and applies to discharges beginning January 1st, 2024. There is no additional guidance with the abstractions that will be begin on July 1st, 2024, so this information has not changed. The updated guidance includes that all medical records must be promptly completed. We all know this. Every medical record must be complete, and all documentation of orders, diagnoses, evaluations, treatments, test results, care plans, discharge plans, consents, interventions, discharge summary, and care provided along with the patient's response to those treatments, interventions, and care. The record must be completed promptly after discharge in accordance with state law and hospital policy, but no later than 30 days after discharge. Further guidance about medical record documentation. The intent of the abstraction is to use only the documentation that was part of the medical record during the hospitalization, is present upon discharge, and that is present at the time of abstraction. An addendum or late entry can be used for abstraction. However, there are guidelines that must be followed. The medical record must clearly and permanently identify any amendment, correction, or delayed entry as such. It also must clearly indicate the date and the author of any amendment, correction, or delayed entry. And finally, it must clearly identify all original content without deletion. Please be aware that the instruction also states it's not the intent to have documentation added at the time of the abstraction to ensure passing of a measure. Another important note is that there are several data elements where abstraction of data from documentation dated and timed after discharge is restricted, and these exceptions are published on the respective data element pages of the data dictionary. Data element specific notes and guidelines always take precedence over the general abstraction guidelines. Examples are severe sepsis, no severe sepsis, and septic shock, no septic shock. So how do we interpret an acceptable versus unacceptable addendum? Let's take a look at an example. In the following example, we have MD documentation of severe sepsis at 2200. The patient was discharged on 3/21. On 4/9, the MD added an addendum that includes the date and time that it was added, and under this date and time stamp, there is also a date and time within the 6 hours of the onset of severe sepsis that states it is not present. So we have the addendum on 4/9 at 1700 by Dr. Jones, and it states within that addendum on 3/10 at 22:05, this patient did not have severe sepsis. So according to the data dictionary, we can accept documentation that is within 30 days after the discharge date, but there are some exceptions, as mentioned on the previous slide. So if we must use the addendum date and time that the addendum was added to the note, then the outcome will be completely different than if we can use the additional documentation within that addendum that indicates severe sepsis was not present at 22:05. So which date and time do we attach to the documentation of no severe sepsis? According to our guidance from the QualityNet question and answer staff, the documentation after discharge would not be used to determine if severe sepsis septic shock was present or not. The following guidance states that documentation of severe sepsis or septic shock after discharge would be disregarded. The physician documentation indicating severe sepsis or septic shock is not present must be documented at the same time or within 6 hours after the presentation. Disregard any documentation of SIRS criteria, organ dysfunction, and infection, severe sepsis, or septic shock in a discharge note, discharge summary, or documented after the time of discharge. This includes addendums and late entries. Our next abstraction challenge relates to crystalloid fluid, lesser volume ordered and administered. What I'd like to do is review quickly the documentation requirements in order to be able to accept a lesser volume of fluids ordered and administered. The ordering physician, APN PA, documented within a single source, e.g. a note or an order, in the medical record all of the following: the volume of fluids to be administered either as a specific volume or a weight-based volume, and a reason for ordering a volume that is less than 30 cc's per kilogram of crystalloid fluids. Some of the reasons, as we know, include but are not limited to concern for fluid overload, heart failure, renal failure, blood pressure responded to a lesser volume, or a portion of the crystalloid fluid volume was administered as colloids. If a portion consisted of colloids, there must be an order and documentation that the colloids were started and or noted as given. In this scenario, the patient weight is 66.8 kilograms, which equals 2004 cc's target volume. There were no crystalloid fluid boluses ordered or administered within the acceptable time frame. Per ED provider note, despite the patient meeting SIRS criteria, 30 cc's per kilogram of crystalloid fluids may be detrimental. Her only fluid resuscitation at this time will be the volume associated with administered antibiotics and other IV medications. Of note, there was 250 cc's of vancomycin diluent administered at 250 cc's per hour within the specified time frame only. The questions submitted to QualityNet question and answer tool are as follows. Does the 30 cc's per kilogram of crystalloid fluids may be detrimental qualify as a reason? Yes, it does. Simple as that. Number 2, the MD note does not include the specific lesser volume to be administered within the same source as a reason, unless the mention of the only fluid resuscitation at this time will be the volume associated with administered antibiotics and other IV medications. Would this meet the documentation requirement? And the response is no. The above documentation would not be acceptable since the physician did not document the amount of fluids to be administered as either a specific volume or a weight-based volume. And we can't link the 250 cc's of vancomycin diluent as a planned alternative volume to this. So that's that. Okay? In the following scenario, this patient required 2,600 cc's of crystalloid fluids in the setting of septic shock. 2,000 cc's of normal saline were ordered and administered within the acceptable time frame as documented in the fluid orders and the MAR. The EDMD documented the following. The patient has been given 2 liters of fluids and blood pressures responded. Further down in the note, the MD also noted, dialysis patient, given her dialysis state, she will not receive the 30 cc's per kilogram crystalloid fluid bolus as it will be harmful to the patient due to her end-stage renal disease. The question submitted to QualityNet question and answer tool is the following. Does the provider documentation meet the requirements to count this as lesser target volume ordered and administered? The answer is yes. The physician documentation, given 2 liters of fluids and blood pressures responded, can be used as a reason for ordering the lesser volume and the volume to be administered. If the same physician ordered the 2 liters and it was administered within the allowable time frame, the target volume can be the 2 liters. So this concludes the review of our abstraction challenges. Please refer to the following references while you're abstracting, and also, when abstracting, please refer to the applicable version of the Specifications Manual for National Hospital Inpatient Quality Measures that corresponds with the abstraction dates, the discharge dates that you're working with. I want to thank you so much for your time and attention today. I hope that you will take something and put it in your pocket and use it in the future as you abstract sepsis. So again, thank you and happy abstracting.